Hi, everyone, and welcome to the Massachusetts Medicaid Policy Institute's webinar on long-term services and supports in Massachusetts. I'm just going to give folks a few minutes to get into the room and get settled, and then we will kick off the webinar shortly. Great. Okay. Welcome, everyone. My name is Catherine Howitt, and I'm the director of the Massachusetts Medicaid Policy Institute, also known as MMPI. MMPI is a program of the Blue Cross Blue Shield of Massachusetts Foundation. MMPI's mission is to promote the development of effective Medicaid policy solutions through research and policy analysis. We seek to broaden understanding of MassHealth, which is Massachusetts' Medicaid program, and the important role it plays in providing coverage and advancing equity. To stay abreast of future MMPI and other Blue Cross Blue Shield of Massachusetts Foundation resources, webinars, and events, please make sure to sign up for our emails on our website, and the link to do so will appear in the chat shortly. Today's webinar focuses on long-term services and supports, also known as LTSS. These are the critical services and supports that people with disabilities and chronic conditions of all ages use to meet their daily living needs, remain independent, and participate in their communities. Before we kick off today's webinar, I want to offer a little background about the Foundation's work in this space. In early 2022, anticipating the election of a new governor and slate of legislative leaders, the Blue Cross Blue Shield of Massachusetts Foundation partnered with Manatt Health to solicit perspectives on health reform priorities from a broad group of healthcare stakeholders, including consumers, providers, health plans, businesses, and labor representatives. One of the 5 priorities that emerged from those conversations was to improve affordability of and access to long-term services and supports. But what we noted in those and subsequent stakeholder conversations was that many stakeholders felt they didn't have one go-to source of information about how LTSS are currently paid for or accessed, or on the strengths and challenges of LTSS delivery and access in Massachusetts today. That gap in easily accessible information on LTSS in Massachusetts is part of why MMPI, partnering again with Manatt Health, recently released a primer on LTSS coverage, access, and affordability in Massachusetts. That primer, which is available on the Foundation's website, summarizes the available data on LTSS payers and programs, utilizations and spending, workforce capacity, and quality in Massachusetts. The webinar that you're a part of today features key takeaways from that larger LTSS primer and is intended to help stakeholders better understand LTSS in Massachusetts. Next slide. So with that, I want to introduce the speakers for today's webinar. In addition to hearing from myself, we'll also be hearing from Stephanie Anthony, who is a senior advisor at Manatt Health, from Nate Paul, who's a senior manager at Manatt Health, and from Lauren Sears, who is a manager at Manatt Health. Stephanie, Nate, and Lauren are 3 of the 4 co-authors of the recently released primer on LTSS coverage, access, and affordability, from which the information for this webinar is drawn. Next slide. So what can you expect in today's webinar? So after I finish this welcome, we'll be handing the webinar over to the team at Manatt, whose presentation is divided into 4 sections. First, they'll start with a brief introduction to long-term services and supports. Second, they will cover how LTSS is paid for and delivered in Massachusetts today. Third, they will summarize what we know about LTSS utilization and spending in MassHealth, which is the largest payer for LTSS in the Commonwealth. And finally, we will review what we know about LTSS system performance here in Massachusetts and discuss options for improving access to and quality of LTSS in Massachusetts. After their presentation, we'll stop to answer your questions on this topic. So you can submit a question at any time during this webinar, and to do that, please click on the Q&A icon located at the bottom of the Zoom window. Finally, after we take 10 to 15 minutes to answer your questions, we will wrap up the webinar by summarizing today's key findings. But before I kick it over to Stephanie, Nate, and Lauren, there's one last thing that we need to do. We're going to be giving you a few survey questions to test your prior knowledge of some of the issues that we'll be discussing today. And then at the end of the webinar, we'll ask you to complete these same survey questions again. And your answers will just help us to determine whether we're effectively conveying some key pieces of information about LTSS in Massachusetts. So let's start with one of those questions now. That question will pop up on your screen, and you'll see they have multiple choice answers. Please just choose your answer and submit it. And if you don't know the answer, just take your best guess. These responses are anonymous, so we won't know what you put in. So the question here is, which of the following types of insurers pay for comprehensive LTSS? Private commercial health insurance, Medicare, Medicaid, or all of the above? See, the answers are coming in, and I'll just give you a few more moments to submit your answers. Okay, let's move on to the next poll question, and I'll be giving you the answers at the end of this webinar, but let's move on to the next poll question. So the next question is, what portion of LTSS care is provided by family or informal caregivers? Is it none? Is it a third? Is it half? Or is it over 2/3? And again, just take your best guess. We won't know who answered what. So just give it your best shot. Okay, I see the answers are slowing down now. So I think we'll try to move on to our last question here. And that should pop up on your screen shortly. Which of the following are true? Is Massachusetts a national leader in LTSS system performance? Are LTSS costs in Massachusetts higher than the national average? Do people in Massachusetts typically rely on Medicaid / Mass Health or on self-pay for LTSS? Or are all of the above true? Just waiting for you all to finish answering this question. Great, it looks like we're slowing down in our responses now. So I think we'll end this poll. And again, we'll revisit these questions again at the end of the webinar, and we'll provide the answers at that time. And with that, I'm going to hand it over to Stephanie Anthony from Manatt Health to kick off the content for this webinar.
Great, thank you, Catherine. You can even go to the next slide. So yeah, I'm going to provide some background on long-term services and supports. Starting by defining what are long-term services and supports, or LTSS. LTSS is an umbrella term to cover the broad range of medical and non-medical services and supports that older adults and people with disabilities of all ages and people with chronic conditions of all ages, and they're used to meet their medical, personal care, or daily living and community participation needs. LTSS can be provided in people's homes, such as wound care or assistance with bathing, dressing, or house chores. They can be provided in people's workplaces, such as job coaching, and in community settings, such as adult day health programs. They also can be provided in institutional settings, such as nursing facilities. When provided in homes and community-based settings, this is often referred to Home and Community-Based Services, or HCBS. These services are designed to help people with functional limitations live independently and stay in their homes and communities rather than move into a nursing home or other residential facility. Some people with complex care needs, however, may require the continuous care that's provided in these institutional settings and may use nursing facility services or chronic disease and rehabilitation hospital services. As we're going to talk about in a bit, Medicaid, called Mass Health in Massachusetts, is the largest payer for LTSS, but the examples of LTSS on this slide are not specific to any one payer. For example, Mass Health does not typically cover assisted living facilities, although assisted living is a community-based LTSS. You can go to the next slide. So who uses LTSS? LTSS address the daily living needs of people with functional limitations across the lifespan, including children with special healthcare needs and people of all ages with physical disabilities, intellectual or developmental disabilities, brain injury, behavioral health conditions, and cognitive impairments, including dementia. People who use LTSS often use these services and supports for extended periods of time and sometimes throughout their lives. While children under age 18 with special healthcare needs comprise a small percentage of the population using LTSS, they actually can have substantial LTSS needs that last a lifetime. Most children who use LTSS have physical disabilities such as cerebral palsy or spina bifida, or intellectual and developmental disabilities, including autism spectrum disorders and Down syndrome. In Massachusetts, 1 in 10 adults ages 18 to 64 report living with a disability. And adults with disabilities in Massachusetts also have disproportionate rates of certain health conditions, such as depression, diabetes, and heart disease that may increase their need for LTSS. Older adults who are most likely to need LTSS due to cognitive or physical limitations as they age are the fastest growing cohort in the population and will comprise close to 20% of the Massachusetts population by 2040, and this is up from 14% in 2010. Older adults use LTSS for physical functional limitations primarily caused by arthritis, heart conditions, diabetes, stroke, and dementia. You can go to the next slide. But LTSS needs may vary and do vary by race and ethnicity. Nationally, Black and Hispanic Latino older adults consistently report poor health outcomes and health status relative to white older adults. This is not a data point on the slide, but national data from the CDC, the Centers for Disease Control and Prevention, also show that prevalence of both diabetes and hypertension is higher for Black older adults relative to other groups. Together, disparities in overall health status and in chronic conditions and chronic illness may drive increased LTSS needs among Black and Hispanic or Latino older adults. Additionally, from 2020 to 2060, so coming up, the proportion of older adults in the United States who are Black, Asian, and Hispanic Latino is expected to grow, while the share of older adults who are white is expected to decrease accordingly, potentially also creating disproportionate need for long-term services and supports among communities of color. As prior foundation and other studies have shown, there remain large gaps in comprehensive population-specific or service-specific data on racial and ethnic health disparities in Massachusetts. More work needs to be done. We'll talk a little bit more about this later in this area to better illuminate disparities in LTSS needs, access, and outcomes. You can go to the next section. So now we're going to delve a little bit into some of the background on LTSS payment, coverage, and delivery. And I'm going to start, you can go to the next slide. So I'm going to start by talking about how much long-term services and supports cost, because LTSS can be quite expensive, particularly if used for long periods of time, and particularly in Massachusetts, candidly, with its high cost of living and high cost of care. Across nearly all major settings of LTSS care, Massachusetts' average LTSS costs per year are higher than the national average and higher than Massachusetts' median household income of roughly $57,000 for older adults. By the way, this graphic is actually similar if you looked across New England states. It's not just Massachusetts. The New England states often have high costs of care also, so this looks similar in some of the other New England states. And these LTSS costs make it very difficult for many people to afford long-term services and supports. Most people don't think they're going to need LTSS or don't want to think about needing it, but well-known national research, most recently updated by the Federal Department of Health and Human Services in 2022, indicates that nearly 70% of people turning age 65 will develop significant LTSS needs in their lifetime. And about 45 to 50% of those people will need paid LTSS. We'll talk more about this shortly, but many people also use long-term services and supports from unpaid, informal family caregivers, neighbors, and friends. But here we're talking about paid LTSS. Over 20% of people needing to use paid LTSS will need it for more than a year, with 14% of people needing it for 2 or more years and 4.5% of people needing it for more than 5 years. This projected need is not evenly distributed across populations, of course. So, for example, older adults with few financial resources may experience more severe LTSS needs and therefore costs. You can go to the next slide. I'm going to spend a minute on this one because it's kind of fundamental to the rest of the presentation. So, for people who need paid LTSS, who pays for it? This bar chart shows national LTSS expenditures by payer. Current data on LTSS expenditures by each payer is not available for Massachusetts, although it is expected that these national trends hold true in the Commonwealth. An older report from about 2010 that did try to replicate this for Massachusetts confirmed that point. The key takeaway of this slide is going to be that Medicaid, again called Mass Health in Massachusetts, is the primary payer of long-term services and supports. It's 44% of total paid LTSS nationally, with some people paying out of pocket or self-paying for these services. And we're going to talk about both of those in a minute. So in summary, the public sources, Medicaid, Medicare, and Veterans Health, and then some state-funded facilities for people with intellectual and developmental disabilities, severe mental illness, and substance use disorders, pay for about 70% of paid long-term services and supports, with private sources, and those are people self-paying, commercial insurance, and private long-term care insurance accounting for the rest. In reality, though, Medicare, which is the federal insurance program for 65 million older adults and some people with disabilities, and commercial insurance cover only a subset of LTSS, typically for a limited duration of time, such as skilled nursing facility or rehabilitation services following a hospital stay. This is often called post-acute care, or short-term home health services, hospice, and palliative care. And the private long-term care insurance market is small, 7% nationally. I think a prior report by the foundation showed it was about 8% of eligible people in Massachusetts have private long-term care insurance, but it's expensive. People have to buy it when you're about age 40 or 50 to be able to afford it, so well in advance of your anticipated need. And the market is pretty volatile with a lot of premium increases and actually insurers dropping out of the market. So Medicaid is the primary payer of LTSS in the United States and in Massachusetts, particularly for low-income people and people who may need to use LTSS for an extended period of time. In general, lower-income seniors and people with disabilities can access LTSS through Medicaid, and Lauren is going to talk in a minute about Medicaid financial eligibility levels to be able to access these services and through Mass Health. However, many people with higher income and asset levels who have high medical or long-term services and supports expenses can spend down or exhaust their resources paying for LTSS out of pocket until they become financially eligible for Medicaid. It's called impoverishing. They impoverish themselves, basically. This spend down process is what happens to many Medicare beneficiaries whose health eventually declines and they need to go into a skilled nursing facility. Medicare will pay for the first few months of that care, and then the person may need to self-pay until they can't anymore, and then they become eligible for Medicaid. These people are often referred to in the policy world as dually eligible individuals or dual eligibles because they are eligible for both Medicare and Medicaid. So with that, I'm going to turn it to Lauren to provide more context about Medicaid coverage and eligibility.
Thanks, Stephanie. So as Stephanie mentioned, we do not have equivalent LTSS expenditure data by payer at the state level, but on this slide, we've broken out health insurance enrollment by payer for Massachusetts residents. Roughly 26% of the state's insured population receives coverage through Mass Health, which, as we've discussed, covers a broad array of LTSS. The remaining 3/4 of Massachusetts residents have private commercial coverage or Medicare, which covers only a subset of LTSS for a limited duration of time. Therefore, most people in Massachusetts who need a broader set of LTSS on an ongoing basis rely on Mass Health, private long-term care insurance, or self-pay to cover these often costly services. Due to the lack of coverage options for LTSS, the state is working to identify alternate LTSS financing options. The Massachusetts state fiscal year 2024 budget included funding for an actuarial study on a statewide long-term care insurance program, which is currently being commissioned by the state. Eligibility for Mass Health is dependent on age, disability status, and income and asset limits. Among Mass Health members, access to LTSS benefits also varies based on these factors. In general, older adults and people with disabilities are eligible for Mass Health at low income and asset levels, and some children and adults with disabilities may also be eligible for Mass Health at higher income levels, but may have cost sharing requirements. Most individuals ages 65 and over can only access Mass Health community-based LTSS if their income is below 100% of the federal poverty level. They cannot qualify for Mass Health if they have assets over $2,000 for an individual or $3,000 for a couple. As a result, many older adults are forced to spend down their income and assets paying for care until they can become eligible for Mass Health coverage. Mass Health covers a wide array of LTSS, including through special home and community-based HCBS waiver programs for individuals with certain care needs to receive care in the community as an alternative to nursing home care. Mass Health has used these waivers to expand access to services for people with slightly higher income levels, up to 224% of the FPL, if they meet certain specific clinical criteria. Switching gears here from our discussion on eligibility and coverage to provide a brief overview of the LTSS workforce. In Massachusetts, 16% of the LTSS workforce is comprised of formal paid LTSS workers. The majority of this care is provided by direct care workers, such as certified nursing assistants, home health aides, and personal care attendants, who are often employed by home health and home care agencies. The remaining 84% of LTSS are provided by unpaid informal caregivers, such as family members and friends. Informal caregivers often assist the LTSS population in performing daily activities, such as bathing or using the bathroom, but they may also perform more complex nursing tasks, such as wound care or medication administration. In 2021, nearly 780,000 individuals, or 11% of all state residents, provided informal, unpaid LTSS care in Massachusetts. The estimated economic value of family caregivers' unpaid contributions in the state equates to over $15 billion. While informal caregivers may actively choose to provide care, they also fill gaps in care resulting from direct care workforce shortages. These shortages are the result of both a growing demand for LTSS and historical underinvestment in the formal LTSS direct care workforce. And to further illustrate this underinvestment, in Massachusetts, the median hourly wage for direct care workers was $17.59 in 2021, which fell short of the living wage in the state, which was $21.88 for a full-time working adult with no children. I'm now going to turn it over to Nate to discuss LTSS utilization in the Mass Health population.
Great, thanks so much, Lauren. So as Lauren said, we'll spend the next few minutes talking about LTSS utilization and spending among Mass Health members. Before we jump into it, I do want to say that on the next few slides, you're going to see a few graphs and figures that capture data points related to Mass Health LTSS utilization and spending. These graphs and figures are based off data that was generously provided by Mass Health for the purposes of this report. First up, we'll take a look at overall LTSS utilization among Mass Health members. This slide gives an overview of the percent of Mass Health members that used LTSS in state fiscal year 2022. Here you can see that in state fiscal year 2022, 12% of Mass Health members, or about 300,000 individuals, used LTSS. Most Mass Health members who used LTSS received LTSS through the Mass Health Fee-for-Service Delivery System, or FFS, as it's represented here on the slide. In the Fee-for-Service Delivery System, Mass Health pays providers directly for each service received by an eligible member. Here you can see that 7% of Mass Health members, or about 175,000 individuals, received LTSS through the Mass Health Fee-for-Service Delivery System in state fiscal year 2022. This does include some people who may be enrolled in the Mass Health Accountable Care Organizations that received LTSS via the Fee-for-Service Delivery System. Now, although most Mass Health members who used LTSS received LTSS through the Mass Health Fee-for-Service Delivery System, about 5% of members, or about 125,000 individuals, received LTSS via one of the state's 3 integrated care program options for dual eligible members. Now, as a reminder, dual eligible members are typically low-income older adults or people with disabilities who are eligible for both Medicare and Medicaid services. These groups often have high LTSS needs. Most dual eligible members receive care in the MassHealth fee-for-service delivery system, but roughly 30% of dual eligible members are enrolled in integrated care programs administered by MassHealth called the Program of All-Inclusive Care for the Elderly, or PACE, OneCare, and Senior Care Options, or SCO. These programs provide comprehensive Medicare and MassHealth services, as well as additional dental, behavioral health, vision, and community support services. Eligibility criteria for OneCare, PACE, and SCO vary, with age and level of care requirements being the main factors. For example, dual eligible individuals aged 21 to 64 at the time of enrollment may enroll in OneCare. Those aged 65 and older may enroll in SCO, and dual eligible individuals aged 55 and over who meet the criteria for receiving a nursing facility level of care may enroll in PACE. One of the benefits of these integrated care programs is that they also provide access to comprehensive care management and coordination services, which may be particularly important.
I can take over if Nate froze. I'm going to jump in and so I think where Nate was going with this point was the members. So he was talking about integrated care programs, PACE, OneCare, and SCO, how one of the benefits of them, they are integrated care programs that have access to managed care. And I think, Nate, you were just about to go to the fact that many people who use LTSS are also in the fee-for-service system, where comprehensive care management typically doesn't exist. Some of those members actually are enrolled in the MassHealth Accountable Care Organizations, where some of those members who have high LTSS needs can access care management through the long-term services and supports community partners that partner with the ACOs for those members.
That's exactly right. And apologies for dropping. I'm back now and we'll hopefully be able to continue on. Next slide, please. Great. So this slide gives an overview of MassHealth spending among members who used LTSS in state fiscal year 2022. LTSS users comprise a relatively small portion of the MassHealth population, but account for a disproportionately large share of MassHealth spending. So here you can see that although only 12.9% of MassHealth members used LTSS in 2022, total spending on these members, including both LTSS and non-LTSS related spending, accounted for nearly half of all MassHealth spending in state fiscal year 2022. Among the 12.9% of MassHealth members who used LTSS in 2022, over 28,000 received LTSS through one of the state's 10 home and community-based services waivers. Total home and community-based services waiver spending in 2022 was over $2 billion.
Seems like we have lost Nate again. Stephanie, I don't know if you want to jump in here, or alternatively, I could just jump to some of the questions that have been coming in from the chat. I defer to you on your preference here.
Want to ask a couple questions from the chat?
Sure. Yeah, let's do that.
Jump back in.
And just as a reminder for folks, please submit questions via the Q&A feature at the bottom of the Zoom window. So Stephanie, one question that's coming up is around Aging Services Access Points, or ASAPs. Can you talk about what they are and what role they play in the provision of LTSS in Massachusetts?
Yes, I can. I will say in the primer itself, the full report, we did not do a deep dive into the provider infrastructure and community-based organization infrastructure that supports the entire LTSS system. However, the ASAPs are the Aging Service Access Points. They are the AAAs, the Area Agencies on Aging in Massachusetts, and together with the independent living centers, really are the community-based infrastructure of the entire LTSS system and the entire aging and disability network. They provide many services and supports to older adults and people with disabilities in regions across the Commonwealth. They're regionally organized, so the entire state's covered. And they provide just critically important information and referral services, navigation supports directly to people and their family members and caregivers. They provide needs assessments for many of the programs that Mass Health covers for LTSS. They provide care coordination supports and services. So really just an integral and, community-based part of the system.
Great. And thank you. And I see that Nate is back, but let's just take time to answer one more question maybe before we throw it back to Nate to continue the presentation. So we're getting questions about how Medicare pays for short-term, long-term services in LTSS. The people are saying like too many people assume that they get a certain number of nursing home care days under Medicare, but that might not always be true. Can you just dive into that a little bit for us?
Sure. So I did see that comment, and the commenter is correct. While Medicare, I was talking about how Medicare covers, limited LTSS or short-term use of LTSS, often after a hospital stay called post-acute care. But there's a lot of Medicare rules and regulations that even further limit access to those services. So the commenter mentioned one around the need for skilled services and when those nursing services kick in. There's some around home health, and you have, a need to be homebound to access those services. So even though Medicare does cover some LTSS on a short-term or limited set of services, there's even further regulations within the Medicare program that kind of further limit Medicare's coverage of these services.
Great, thank you. And Nate, are you ready to pick it back up from here?
Nope.
We can't hear your audio.
Can't hear you.
So while we're working through that. Oh, there you are. Okay, great. Thanks.
Great. Okay. Thank you. And apologies for the interruption. I am on my phone now, so if my internet continues to act up, I should be able to keep going. We can go to the next slide. Okay. This slide is giving an overview of the rate of Mass Health LTSS utilization by population type in state fiscal year 2022. We'll note here that this slide only captures individuals who use LTSS via the fee-for-service delivery system, and individuals enrolled in integrated care programs are not captured on this slide. Here you can see that Mass Health members who are older adults and adults with disabilities had the highest rates of LTSS utilization in state fiscal year 2022, with nearly 24% of older adults and 22% of adults with disabilities having used an LTSS in 2022. You can also see here that there are some Mass Health members without disabilities who used LTSS in 2022. These are individuals who are enrolled in accountable care organizations who receive care management services via LTSS community partners. Next slide. And finally, we'll take a quick look at LTSS spending by service setting. Massachusetts is a national leader in terms of the proportion of Medicaid LTSS spending on community-based LTSS relative to institutional LTSS. The figure on this slide shows that 72% of all LTSS spending in Massachusetts in federal fiscal year 2020 was on home and community-based LTSS relative to 62% of all LTSS spending nationwide. Next slide. And now I'm going to turn it back over to Stephanie to spend a few minutes reviewing Massachusetts LTSS system performance.
Great, thank you. Okay, so where are we now? By one very important measure, and I'll explain it in a second, Massachusetts is a national leader in LTSS system performance, but there's some areas which we'll talk about that can be strengthened. This study that we're displaying the findings from is from the AARP 2023 LTSS state scorecard. And it's kind of a seminal report measuring state LTSS system performance across 5 dimensions. You can see the 5 dimensions here. And across these 5 dimensions, there's about 50 indicators or performance metrics that that this report compares states with across the country. So states are ranked relative to each other, and then they're grouped into tiers based on overall performance across these dimensions and indicators. One important note, the scorecard was completely revamped in 2023 to reflect the impacts of the COVID-19 pandemic on states' LTSS systems, which I think we all know was enormous. So there, the LTSS scorecard has been, I think they do them like every, I don't know, 2 to 4 years. So 2011, they've been done throughout the past decade or more, with again this big revamp in 2023 to capture post-COVID impacts. In the 2023 report, Massachusetts was one of 5 states to reach top tier performance, with Minnesota, Washington State, the District of Columbia, and Colorado, and Massachusetts ranked 4th overall in the country. Massachusetts performed strongest in dimensions related to choice of setting and provider, and affordability and access. I'll explain that in a minute, because I already talked about the high costs of LTSS in Massachusetts. But again, related to choice of setting and provider and affordability and access, they ranked 2nd. Massachusetts ranked 2nd and 4th in the country, respectively. While Massachusetts does have higher costs for home care and nursing home care, as we already talked about, it did outperform other states on the access and affordability dimension overall, because of the strong performance in access to Medicaid, Mass Health covered LTSS for low and moderate income people with disabilities. While Massachusetts continues to make significant investments in increasing utilization of and spending on community-based LTSS, that rebalancing or shifting of LTSS spending from institutional settings to community-based care, as Nate was just describing, and expanding access to care coordination and care management services, among many other initiatives, the scorecard does identify several areas for improvement in the LTSS system, including access to housing, affordable housing for populations who use LTSS. That's one of the community integration measures. There were a couple around housing, actually. And enhanced support for unpaid family caregivers. While Massachusetts does provide respite services and many other services and supports to unpaid family caregivers, there was more that could be done around tax credits for family caregivers and some other financial relief. And another area was around safety and quality, particularly in nursing facilities. Of note, the scorecard did identify disparities in quality among nursing facilities in Massachusetts that had disproportionately high numbers of Black and Hispanic residents relative to other nursing facilities. So again, really strong, obviously 4th in the nation, high, looking across all dimensions and all 50 of the measures. But when you delve a little deeper under some of them, again, particularly some of the ones around community integration and access to some of the, affordable housing that's critical for these populations, for unpaid family caregiver supports, and safety and quality, particularly in nursing facilities, there is some more work to be done. You can go to the next slide. Okay, so where does Massachusetts go from here based on everything that we described in the scorecard and all of the work it's done to date? As noted, Massachusetts is a very strong long-term services and support system, but there are opportunities to improve access to and quality of LTSS in the state. Specifically, the Commonwealth could and really must continue to explore strategies to increase LTSS workforce capacity, including enhancing efforts to ensure sufficient wages, benefits, and training for direct care workers in both community and institutional settings, and provide tax credits or other supports, financial and non-financial, for family caregivers to help them not only with their out-of-pocket expenses, but also any type of other support they need. Massachusetts did use much of its, there was some COVID relief dollars that Massachusetts heavily invested. It was time limited, but Massachusetts did really focus on LTSS workforce improvements using those dollars. The Commonwealth can continue to expand access to community-based LTSS, including advancing care at home models that enable people who need LTSS to receive these and other services in their homes and communities. Massachusetts is pursuing one model to look at not an actuarial study, a clinical trial actually to look at providing post-acute care at home versus in nursing facilities and what that may look like. The state can prioritize increasing LTSS payment options for moderated income residents. This long-term care financing issue, again, we talked earlier about Mass Health or Medicaid being the primary payer of these services. I think there again is more work to be done on promoting financing options for residents who do not qualify for Mass Health. Lauren mentioned the actuarial study that will be getting underway. There might be some other approaches there too. And finally, the Commonwealth can enhance data quality and transparency about LTSS needs, usage, and costs in the Commonwealth, including collecting better data on race, ethnicity, and primary language spoken among people using LTSS. And again, I think there's already work going on in this area and more to be done. And I think with that, I am turning it to you, Catherine, for more questions.
Great, great. So again, we've got a lot of questions coming in through the chat. This is wonderful. Please, if you have a question you want us to answer, please submit it through the Q&A feature at the bottom of your Zoom screen. So Stephanie, actually, a really basic question, but I think a really important one. What defines long-term services and supports? Is it the length of time the service is provided, or are some services always considered LTSS, even if some people use them only for a brief period of time?
That is an excellent question. There is no one definition nationally on LTSS. I think that the term long-term is in the definition of the word, so it does encompass or envision more use of these services and supports over some extended period of time instead of needing a durable medical equipment like a wheelchair after a hip replacement. So there are services like DME, durable medical equipment, that use for an extended period of time or more captured in the definition of long-term services and supports versus short-term, possibly after a hip replacement or something. I'm making these up, but I don't, again, know one definition, but I do think there is some visioning around extended use of these services, because ultimately the people using these for long periods of time are people with functional limitations who might need this over, again, a longer period of time.
Thanks, Stephanie. So I think a question here that I think I'm going to throw to Lauren. The person is asking, what % of the members who used fee-for-service long-term services and supports are duly eligible? So this person is sort of acknowledging that there's a bunch of people who are duly eligible who are in integrated care programs who are represented elsewhere in our charts, but of the people who used fee-for-service LTSS, how many of them are duly eligible and maybe not enrolled in an integrated care program?
Sure, great question. Roughly 42% of fee-for-service LTSS utilizers in the latest data that we have are duly eligible. So roughly 42%.
Okay, great.
Quick
So we
answer.
also have some questions coming in. There's a number of questions. I'm going to throw these to Nate. Nate, there's a bunch of questions just asking about further demographic breakdowns on who is accessing LTSS services, specifically by race, ethnicity, sexual orientation, gender, etc. And I'm wondering if you can speak a little bit about what we know and also what we don't know and where there might be limitations in the data on these questions.
Yeah, happy to, Catherine. So data is available about the demographic breakdown of individuals who use LTSS in terms of demographics like age and gender. But where we really fall short are going to be on other indicators for things like race and ethnicity and sexual and gender orientation. These are major gaps in terms of our ability to better understand disparities and equity when it comes to utilization of LTSS. Even things like member race and ethnicity, this is data that is collected by Mass Health, but data on member race and ethnicity is frequently inaccurate or missing or incomplete in the Mass Health data. And so it's something that even though some information on that is available, we really don't have enough confidence in that to be able to accurately use that information to help us identify disparities and issues related to equity. And would flag that as a major, thing that should be worked on in the future, is to collect better data around these types of indicators so that we can better use this information to better understand equity and disparities.
Great, thank you, Nate. And actually, here comes a related question, and I might throw this to Stephanie. What are the opportunities to improve health equity in LTSS?
So there's a lot. I will say, so Nate just described some data, big data gaps and more data work that can happen in this space. But I think I want to start by noticing that, while there is not a lot of data in this space and more work needs to be done, there is some data on some of the challenges here. And I'm just going to read, I'm actually reading off a piece of paper because they're from the COVID-19 pandemic, there was some data that looked at that found nursing homes serving populations significantly composed of African American and Latinx individuals were twice as likely to face a COVID-19 outbreak compared to facilities with a majority white population. Also, nursing homes that serve predominantly Black and Hispanic residents have been associated with lower levels of staffing, higher numbers of government-cited nursing home deficiencies, and lower quality of life. So there is some data around disparities in the LTSS space, even though much work needs to be done. As part of the work we did for the foundation, actually, we looked at best practices around health equity. And one thing we found nationally and in Massachusetts was actually a lack of best practices in this space around improving health equity around LTSS. So some of the things we did find, and that could be deployed in Massachusetts even more than they are now, is really that focus on increasing awareness of LTSS programs in a culturally responsive way. So really targeted strategies around outreach and awareness for these programs for populations experiencing homelessness, enrollees with limited English proficiency, and in communities of color. Thinking more strategically about what kind of the nursing homes of the future, or institutional care of the future, should look like in a way that's more culturally responsive than it is now. Maybe there's some models called greenhouse and small house models that are more look like community-based settings, smaller. Everyone has private rooms with a joint kitchen area and sitting areas that are just easier to address people's issues. Addressing specific social drivers of health more in a targeted way. And really, this is where family caregivers and paid home care workers, really, they're on the ground at people's homes. They can see a lot more than what's going on in terms of addressing unmet social needs. So I think there's many areas where we can just do a lot more to kind of, illuminate some of these challenges and address them in a more targeted and specific way.
Thank you, Stephanie. Actually, a few people now have brought up questions that relate to the intersection between behavioral health and long-term services and supports. What can we say about sort of how much behavioral health issues intersect with long-term services and supports?
I'll start and jump in. So I will just preface this by saying we did not do a deep dive data analytics on the population at that level. However, I do know, and people on the phone, I'm sure know this a lot better than I do, but I will say what I know from prior work. In developing OneCare, which is one of the integrated care programs for dual eligibles under age 65, adults under age 65, the state did do a deeper dive on the population in terms of their projected, demographic profiles and projected utilization in building that program. And one data point always stuck out to me that I think it was about, and people can correct me later or through the chat, but about 70% of that under age 65 dually eligible population had some level of behavioral health need. There is a huge intersection, not only with older adults in dementia, but younger children and non-elderly adults with intellectual and developmental disabilities. There was just a piece on the news about the intersection of populations with intellectual and developmental disabilities. having high prevalence of behavioral health conditions. So we actually talk about it a lot with our colleagues at Manette. This is an underexplored area. There's a huge intersection of people using LTSS and having behavioral health needs.
Okay, I think we have time for one last question. So this person asks, and Stephanie, I think I'm going to throw it to you.
Okay.
If we can elaborate on the differences between getting long-term services and supports through fee-for-service versus getting it through integrated care, specifically from a consumer perspective. And they also asked whether we know anything about whether one is more cost-effective for the state than the other.
Okay, so people who are receiving long-term services and supports in the fee-for-service system, again, I want to highlight that some of those people are also enrolled in accountable care organizations where they can access some level of care management. But other than those folks in the fee-for-service long-term services and support system, there's not a comprehensive set of care coordination for those folks. They may be enrolled in one of those HCBS waivers that Lauren was talking about, where they can get some service coordination for those services. But in terms of comprehensive care management or care coordination for all of their services, it is less available in the fee-for-service system. Integrated care programs right now that Nate was talking about, SCO, PACE, and OneCare, are mostly open for dually eligible individuals. There's some exceptions to that, but generally they're for dually eligible folks who have both Medicare and Medicaid. That is a choice to enroll in those programs. I think Lauren talked about the percentage that have chosen to enroll in those programs and some who have not. But those programs are, have care management as their model of care fundamentally, as the kind of the core of the program. So they do have access to care management there. In terms of comparatives across the two models of care right now for people using LTSS, there are not a ton of studies on, there's not a comprehensive study looking across the two. There are some OneCare specific or SCO specific or PACE specific studies that have looked at, cost savings. There's some mixed, findings around reduced access to, reduced hospital admissions, reduced SNF skilled nursing facility admissions from the care management and access to home and community-based services in those programs, but there hasn't been a comprehensive study. And actually that's another area where, there might be work to be done there too.
Thank you so much to the full Manette team for answering so many questions, and really appreciate all of the audience participation here. We got so many wonderful questions and really appreciate that. Before we wrap up and take our final survey, I do want to take a few moments to just review some of the key takeaways from today's webinar. So today, if you could go to the next slide, thank you. So today we looked at who uses LTSS in Massachusetts, and we found that people of all ages can have LTSS needs. Most people who use LTSS in Massachusetts are older adults, age 65 and over, as well as adults and children with disabilities. As the Massachusetts population ages, the demand for LTSS is expected to continue to grow, which will increase pressure on the LTSS workforce. This in turn may increase pressure on family or informal caregivers who already provide over 2/3 of LTSS care today. We also looked at the care delivery for long-term services and supports. And we found that through MassHealth, Massachusetts has expanded access to community-based LTSS and to care coordination programs for people with high LTSS needs. But as Stephanie was just talking about in her answer to the last question, we know there is more that can be done to connect members to these services. We also looked at costs for long-term services and supports and found that costs for most LTSS in Massachusetts are higher than the national average. We also found that most insurers, including private commercial health insurance and Medicare, do not comprehensively cover these services. As a result, many Commonwealth residents with high LTSS needs ultimately need to spend down their income or assets paying for these services until they become eligible for MassHealth coverage. Finally, we looked at LTSS system performance. And we found that Massachusetts is a national leader in LTSS, ranking 4th among states on LTSS system performance. At the same time, we found that there is room for strengthening the system, particularly related to LTSS affordability and LTSS safety. And so before we go, we do want to see how well we did in imparting this important information to you. So please take a few seconds to answer the 3 questions again that you already saw at the beginning of this webinar so that we can measure how your knowledge has improved. So the first question should, here it is, pop up on your screen. Which of the following types of insurers pay for comprehensive LTSS? Private commercial health insurance, Medicare, Medicaid, or all of the above? Okay, our answers are starting to slow. So I'll just mention before we move on to the next one, so that we're offering the answers. The correct answer here is Medicaid, and so in Massachusetts, that's MassHealth. Is the one insurer that offers comprehensive long-term services and supports in Massachusetts. So with that, we'll move to the next question, which will pop up on your screen shortly, and it's going to ask what portion of LTSS care is provided by family or informal caregivers. Is it none? Is it a third? Is it half? Or is it over 2/3? I'll give you a moment to answer that question. I see the answers are starting to slow, so I'll give you the answer here. So the answer is over 2/3. So the vast majority of LTSS care in Massachusetts is provided by family and informal caregivers. So we'll move on then to the last question here. Which of the following are true? Is Massachusetts a national leader in LTSS system performance? Are LTSS costs in Massachusetts higher than the national average? Do people in Massachusetts typically rely on Medicaid or MassHealth or self-pay for LTSS, or are all of the above true? Okay, it looks like answers are starting to slow down here. Okay, it looks like answers are starting to slow down here. So we will end this poll. And I just want to thank you all for joining us today. Oh, actually, I should have mentioned the correct answer was all of the above there. So I just want to thank you all for joining us today, and thank you, Stephanie, Nate, and Lauren for that really informative presentation and for answering so many questions with so much information and expertise. We really appreciate your sharing of your expertise with us today. If you have any additional questions, I have provided my contact information on the last slide of this deck. You can also find the full LTSS primer on our website. A link to a recording of today's webinar and the webinar slides will be posted on the Foundation's website. Finally, to stay abreast of future MMPI and other Blue Cross Blue Shield of Massachusetts Foundation resources, webinars, and events, please make sure to sign up for our emails on our website. And finally, I just want to thank you all for your time and attention and for your interest in this important subject. And I hope you have a great day.